itself is guiding you that it is something related to urination. So there are certain conditions in the body sometimes which result in just wait a minute. I think I'll go with this one. So there are certain conditions in the body sometimes when there is a fluid overload and there is collection in the something is wrong with this. So there are third space collections. There can be edema due to which due to the cardiac origin, due to the renal origin or the hepatic origin, which can result in a lot of accumulation of body fluids. I put this small this thing for you. I think it's not working. Anyway, so we'll have a look at the outline of this presentation. So first we'll deal with a little bit of renal anatomy and then physiology. Then we'll have a look at the 4 sites of solute reabsorption which are there in the tubules, in the nephrons of the in the tubules of the nephron. Then a word about organic ion transport, followed by the regulation of renal function and the relation of the blocking of the solute sites to the diuretic action. So basically, actually, this class will be a revision only of the various things that you've studied in your 12th grade and in your first year of MBBS. So coming to the anatomy first. Anatomy, I think everybody knows this, and maybe even in your pathology, you've covered it in much more detail. That the basic unit of formation, unit of urine formation is nephron. Nephron. And the nephron has broadly 2 parts. The first one is the filtering apparatus, which is called the glomerulus. And the second one is the many tubules that the nephron has, like the PCT, DCT, etc. So coming to the first part, that is the glomerulus. Glomerulus is nothing but a tuft of capillaries, which are enclosed in a blind tubular structure, which is known as the Bowman's capsule. This is the Bowman's capsule, which is enclosing the tuft of capillaries, and a lot of convolution is there in the glomerulus so as to increase the surface area for the ultrafiltration. The tubular portion, I think this also you all must be doing. There is a PCT. Okay. So there is a proximal convoluted tubule in this region, the descending limb of loop of Henle, ascending loop of Henle, the distal convoluted tubule, and the collecting duct. It's just a small revision. Okay, so then we move on to the physiology when we see the process of urine formation. So the urine formation occurs under 3 sub-processes. First, there is filtration, then there is reabsorption, then there is secretion. So filtration is the one that we are concerned with more right now. So filtration is the process wherein the proteins and the lipids of the body, they are not excreted by the glomerulus, but the ions and the water that is there from the blood, it is filtered out in as an ultrafiltrate. Then it reaches the various tubules of the nephrons, wherein reabsorption and secretion occurs, and finally the urine is formed. So filtration, this filtration is defined by something known as the glomerular filtration rate, which I'm sure again you must all be doing. So this GFR, it in turn depends on the total filtration surface area. So that is why all that convolution is there, so that there is increased surface area for filtration. Then membrane permeability and the net filtration pressure, which is again, net filtration pressure is an interplay of various pressures, other pressures which are there in the tubules in the kidney, like the glomerular hydrostatic pressure, the capsular osmotic pressure, and the capsular hydrostatic pressure. So an interplay of all these pressures is what causes the ultrafiltrate to be formed. This ultrafiltrate, ideally, it should be devoid of the proteins and the lipids of the body. And what it has is ions, any drugs, and certain organic acids, organic bases, and water. So that is what the ultrafiltrate is composed of. So this diagram I'm taken from K.T. Tripathi only. So this is showing you all the sites of solute reabsorption, the major sites. And these are the sites that are blocked by the diuretics, so that the ion reabsorption does not occur and all those ions are lost in the urine along with water flows. So this is the first site is site 1, which is the proximal convoluted tubule. The second site is the ascending limb of loop of Henle. And then there is this part is there in the cortex, an extension of the loop of the ascending limb only. So this is the cortical diluting segment of the loop of Henle, which is site 3. And the area in gray, which you can see, is the DCT and the collecting duct. So these are the 4 sites where we will look at one by one, that what is happening and then what is, how different diuretics will show their action. So first we'll focus on the first site, which is proximal convoluted. So this is an important site because much of the reabsorption takes place here only. Some entities like glucose, 100% reabsorption occurs. Even bicarbonate, almost more than 90% of bicarbonate gets reabsorbed at this site, and about 60% of sodium. So you can see that this is a very important site of reabsorption. So now just imagine with me here. Imagine that this is the tubular portion or the hollow portion of the tubule, which is called the lumen. So this is the luminal membrane of the tubular cell, and this is the basolateral membrane, or the membrane which is facing the extracellular fluid. So what happens is, the peculiarity of this luminal membrane in the PCT is that it is impermeable to bicarbonate ion. Bicarbonate ion cannot cross this directly, this membrane. So what happens is, sodium bicarbonate is there just in the ultrafiltrate, and this has to be reabsorbed. So there is a pump present on the luminal membrane, which is known as the sodium hydrogen antiporter. So what it does is, it takes in sodium and it throws out hydrogen ion. Right? So this is very simple. Sodium goes in and hydrogen comes out. So the bicarbonate that is left combines with the hydrogen ion to form carbonic acid. Now this carbonic acid is acted upon by the brush border enzyme known as carbonic anhydrase isoform 4. So carbonic anhydrase, it catalyzes the breakdown or formation of carbonic acid only. So it breaks the carbonic acid into water and carbon dioxide. And now, since this has become sort of lipid soluble now, so carbon dioxide and water, they are now able to move inside the cell. In the form of bicarbonate, it was not able to move inside the cell, but in the form of carbon dioxide, it can move inside the cell. And in the cell, again, the same enzyme is present, but a different isoform. So carbonic anhydrase 2 is present, which converts the water and carbon dioxide to carbonic acid and then into bicarbonate subsequently, which is then transferred into the ECF using sodium bicarbonate symport. So you see, using all these complex path, all this very complex path, sodium bicarbonate is finally able to reach the ECF, the extracellular fluid, from the lumen. So I hope this part was clear, because we'll be utilizing the blockade of this. Okay. So there are other methods also by which sodium can get reabsorbed. Like there is, sodium can be reabsorbed along with glucose, along with amino acids, and of course by this elaborate mechanism which I've just told you. This is what is happening in the PCT. So there are other processes also happening, but I'm not focusing on them, because from the diuretic perspective, I'm focusing on only that which is important. So you can see this table. This table is summarizing the ions and the substances which are reabsorbed or secreted in the PCT. Glucose, as I told you, 100% reabsorbed, sodium around 60%, 65%, and 90% of the bicarbonate gets reabsorbed. Then we move on to the second site, or the ascending limb of loop of Henle, which has this peculiar transporter known as the sodium potassium 2 chloride symport or transporter. So this diagram is a little opposite of the one that we saw in the ECT1. So here the luminal membrane is towards the left and the basolateral membrane is towards the right. So this transporter known as the sodium potassium 2 chloride transporter, it has the job of transporting sodium, potassium, and to maintain the electrical neutrality, 2 chloride also, it imports inside the tubular cell. This is there in the ascending limb of loop. So then in the basolateral membrane, there is a sodium potassium ATPase pump, which we all know that it extrudes sodium inside the ECF and it will take in potassium in exchange. So that is the fate of sodium in the ascending limb of loop of Henle. So very simple. Here we have this. All of you, I want you to remember that this is the transporter which is there in the ascending limb of loop of Henle. Now there is something very interesting that in the descending limb of loop of Henle, it's impermeable to ions, but it is permeable to water. So the water progressively, when the ultrafiltrate comes from it is there in the PCT and when it moves down, it is more or less isotonic to the medullary fluid. But as it approaches the loop, a lot of water, since it is permeable to water, a lot of water it goes into the medullary interstitium. And as a result, because of the loss of all that water, the ultrafiltrate now becomes hypertonic, more concentrated. Later, when this ultrafiltrate again goes into the ascending limb of loop of Henle, now here the ascending limb is totally opposite of the descending limb, by which I mean that it is impermeable to water, but it is permeable to all the solutes. So what is happening is that as the ultrafiltrate is moving forward, it is losing salt now because of this sodium potassium 2 chloride channel. And that is why the ultrafiltrate becomes hypotonic later. अब देखो ये जो सोडियम पोटेशियम 2 क्लोराइड channel hai because of all the salt that is transported from the tubules into the medullary interstitium. There is a buildup of a lot of osmolarity in the medulla. And it is because of this high osmolarity of the medulla that the kidney has its concentrated capacity. जितना यहाँ osmotically powerful रहेगा pressure, उतना water यहाँ से conserve हो जाएगा. Water will be able to come into the interstitium and not go into the urine. Okay, so that is the reason for this corticomedullary osmotic gradient. The second important thing here is the blood supply of the nephron, which is done by the vasa recta. Now, vasa recta is very peculiar in the sense that in the cortical aspect of the vasa recta, the lumen of the vessels is a little broader, it has a higher diameter. Whereas as it approaches the medulla, it progressively the lumen gets narrower and narrower. The diameter gets smaller and smaller, so the blood flow becomes less and less as it comes to the loop. So a hairpin type blood supply is there, hairpin loop type blood supply, wherein in the cortex the diameter is more and in the medulla the diameter is less. So what is the use of having this less diameter in the medulla is that it prevents the washing away of the ions that have been collected here, which are responsible for the osmotic gradient. अगर ये diameter बड़ा होता तो यहाँ से बहुत सारे ions का wash out हो सकता था medulla से. So in order to maintain that corticomedullary osmotic gradient, the vasa recta has a smaller diameter in the medulla. So it is helping in the concentrating capacity of the kidney, no doubt, but this is a risk factor also, because whenever there is nephrotoxicity, a nephrotoxic agent that has been given, this area becomes the most prone to ischemia. Because it is very narrow, it can be obstructed, it can be damaged. So, and that narrow part, if it gets damaged, it will compromise the supply to the nephron and renal injury can happen. So, renal papilla, where all these vasa recta they converge, it is the most sensitive portion of the kidney, maybe, because it is very any blockade can cause a lot of ischemia over here. So that was about the countercurrent mechanism, the vasa recta, and the flow of the ultrafiltrate. I hope it was a little bit clear. I know it may be difficult to grasp at once, but once if you go and read this again, I'm sure you will be able to keep that in mind as we move ahead. So again, a summary of the absorption and all the processes occurring in the ascending limb of loop of Henle. So sodium, chloride, potassium, they all are reabsorbed here. And in the descending limb of loop of Henle, water gets reabsorbed, as I told you, because the permeability to water is there in the descending limb, not in the ascending. Then we are moving on to the third site. So abhi हमने site 1 कर लिया, where I told you elaborately the bicarbonate reabsorption that is occurring because of the help of carbonic anhydrase enzyme. Carbonic anhydrase 4 and carbonic anhydrase 2. Then the site 2 was ascending limb of loop of Henle, which had sodium, potassium, 2 chloride. ये सब आपको याद करनी है. Sites you have to remember, okay? I'm not interested in the sites per se, but I want you to remember that which site has what. कौन सी site में कौन सा ion channel है, वहाँ पे it should be ingrained engraved into your mind, so that in the next lecture you are able to better understand the functioning of drugs. इसी को modify करते हैं वो. Am I going too fast? Just tell me if I'm going too fast and you're not able to understand. I'll go a little slower. No. Okay. So site 3. Now we move on to site 3. So site 3 is cortical diluting segment. ये थोड़ा सा डायग्राम में ना आपका इतना बेंड नहीं आना चाहिए था यहाँ पे. But anyway, since KDT has made it. So site 3 is the cortical diluting segment of loop of Henle. So here we have, just as in the ascending limb we had sodium potassium 2 chloride channel. At this site we have sodium chloride symptom. Very simple. Okay. So sodium potassium 2 chloride इसमें था और इसमें sodium chloride symptom. So this is blocked by the action of one class of diuretics known as thiazides. We'll be studying about this in the next class also. Right now, just remember that this site has sodium chloride symptom. And again, the same way, the fate of sodium is similar here. That sodium goes to the basolateral end, wherein it is exchanged with the help of sodium potassium ATPase with potassium. And sodium moves into the ECF from the lumen this way. So nothing more here. Just the idea of this lecture is only to make you remember the different transporters at each. So, a very little bit of reabsorption is occurring here. So, blockade of these sites is not very powerful. Blockade तो वहीं ज़्यादा effective होगा ना जहाँ पे आपका reabsorption भी ज़्यादा हो रहा है. So at this side, the reabsorption is not that much. So even with blockade, the diuresis will not be that much. Okay. Then we move to the final site, which is site 4, which is your DCT, distal convoluted tubule, along with the collecting duct. So a peculiarity of this site is that it has special kinds of sodium channels known as amiloride sensitive sodium channels. ये diagram में अंदर और भी बहुत कुछ था. There was a lot of interplay of various things here. So I didn't want to scare you, so I just hit it for now. But in the subsequent slide, the subsequent lectures, we'll see the entire diagram. So for now, what I want to tell you is that on the luminal aspect, there is a sodium channel which is known as amiloride sensitive sodium channel. So amiloride is a diuretic. Since this sodium channel responds to the blockade by amiloride, it is known as amiloride sensitive sodium channel. इसका एक और नाम है, another name is aldosterone sensitive sodium channel. Because very simple, simply because the insertion of these ions are controlled by the mineralocorticoid aldosterone. Now, so at site 4, the sodium moves in, and similarly, there is on the basolateral aspect, there is sodium potassium ATPase pump, which will extrude sodium into the ECF. A word about potassium here. So since all this sodium is coming inside, to maintain the electrical neutrality, a lot of potassium, similar amount of potassium is excreted into the lumen, excreted back into the lumen, so as to maintain a balance in the electrical neutrality. So this statement I've taken directly from KDT again, but it is so important that I had to make us lipids slide out of it. So what the author is saying is that any diuretic acting proximal to the aldosterone sensitive ion exchange site causes an increased delivery of sodium to the distal nephron. तो इसका मतलब क्या है? It means that any diuretic which is acting on a site which is before site 4, which means if a diuretic is acting on site 1, site 2, or site 3, which is the PCT, ascending limb of diuretics, when a diuretic acts on this, so it is preventing the reabsorption of sodium from this site. So as a result, the sodium from site 1, 2, or 3 will move to site 4. Okay, all that has now been reabsorbed and moved to site 4. And more the sodium comes at site 4, more the potassium will be lost at site 4. Okay, जितना ज़्यादा सोडियम साइट 4 पे आएगा utna zyada potassium will be lost. So the diuretics which act at site 1, site 2, and site 3, one of the side effects of such diuretics is hypokalemia, because of what I just said. Because these diuretics, they block site 1, site 2, and site 3. So more sodium comes to site 4, and if more sodium comes to site 4, more potassium will be lost at site 4. That is why the drugs acting on site 1, 2, and 3 can cause hypokalemia. Is that clear? Yes, so Ansh had asked a question. This amiloride sensitive sodium channel is ENaC only. So yes, that is the ENaC channel, which is ENaC stands for epithelial sodium channel. ENaC. So that is that one. So I hope I was clear here about site 1, 2, and 3 being blocked and sodium coming to site 4. So a word about the role of antidiuretic hormone. So antidiuretic hormone, it's secreted from the pituitary gland, especially in times of water deprivation. So another feature of the collecting duct and the late DCT is that they are responsive. They are very responsive to the action of the antidiuretic hormone. So whenever the body senses that there is hypovolemia, or electrolyte or water is less there in the body, so ADH is secreted by the pituitary, and ADH acts on the collecting duct cells, where it inserts a channel known as aquaporin 2. So aquaporin 2 वो collecting duct में डालता है. I'll just show you the diagram. So collecting duct में ADH inserts aquaporin 2 channels, which helps in the effective reabsorption of water in times of water deprivation. Okay. So that is how it is. ADH is controlling the urine formation again. ADH has another role, that is, it also inserts urea transporters into the collecting duct, just like it does for water, aquaporins for water. ऐसे ही यूरिया ट्रांसपोर्टर भी डालता है. So इस यूरिया ट्रांसपोर्टर के इंसर्शन से क्या होता है in the collecting duct, that the urea from the collecting duct moves again into the medullary interstitium, and urea is very osmotically powerful again. So it again helps in maintaining the corticomedullary osmotic gradient, which is responsible again for the concentrating capacity of the kidney. So skip this only. So this is a summary of all the ion exchange that is occurring. So sodium ions, most of the reabsorption is occurring at the PCT. Um, the calcium ions similarly, and magnesium ions also. A lot of reabsorption there in the PCT. Potassium ions reabsorbed in the PCT and thick ascending limb and it is secreted in the DCT and collecting duct. Okay. So, and urea, as I just told you, again, is reabsorbed through the PCT and secreted through the. It is secreted in the PCT also, but also in the descending limb and the collecting duct also it is reabsorbed. As I just told you, ADH on a urea transporter. So just a moment. Right. So another important aspect is the organic and organic ion transport. It can be organic anion transport and organic cation. So the PCT, it has non-specific bidirectional active transport mechanism. So non-specific because any order of organic acid, organic base, it can come through this. So it is not very specific. And bidirectional because both reabsorption and secretion can occur through these transporters. So, however, the magnitude of the transport in the two directions may vary from compound to compound. So this means that there are certain substances like you see uric acid. Uric acid is more reabsorbed than it is secreted. Both the processes are occurring for uric acid. Reabsorption is also occurring and secretion is also occurring. But it is just that reabsorption is occurring at a much, much more higher pace than secretion. Okay. Whereas you see another compound like penicillin, more secretion of penicillin occurs into the tubules than reabsorption through these transport. So the magnitude of transport may vary, but the directions may be both ways. Okay. Now these transporters like OATP, organic anion transporter protein, and OCT, which is organic cation transporter, these are the transporters, they are channels through which the diuretics enter inside the tubules and then they act on the luminal aspect at the various sites that we've just seen, the sodium chloride importer or the sodium potassium chloride importer. So the entry of the diuretics is through these organic ion transporters. That is what you need to remember. Now, touching upon the regulation of renal function, so a lot of things are controlling the renal function, the concentrating capacities of the kidney, the urine formation in general. It is under several factors which regulate it. So the first factor, and the most important one, is the GFR, the glomerular filtration rate, which is in turn dependent on the renal blood flow. Renal blood flow will be dependent on the contractility of the heart, the force with which the heart is able to pump the blood. So any discrepancy in the heart, any disorder of the heart will obviously affect the GFR also, the renal blood flow and the GFR also, and it will affect the renal processes, the renal physiology also. So the first and foremost factor is the GFR, which is controlling it. The second factor is the cortical medullary osmotic radius. So 80% of the nephrons, they are there in the cortex, and 20% of the nephrons in the medulla. They are the loops in the medulla, which is responsible for the concentrating capacity. And any damage to these 20% of the nephron, which are the loops inside deep into the medulla, it can cause a redistribution of blood flow, which again can cause kidney injury or failure. Then I think this renin-angiotensin-aldosterone system, it is a separate topic altogether. I think it has been covered by Dr. Kalra. If not, I think it will be covered in subsequent lectures. So renin-angiotensin-aldosterone system, any idea how it can control the urine formation? What is the final product of the renin-angiotensin system? Angiotensin 2. Right. So many of you have written angiotensin 2, but there is further aldosterone also formed. Many people have written aldosterone also. So, right. So once the RAS gets activated, aldosterone is released, and aldosterone we just saw, it inserts the ENaC channel in the site 4. So there it can cause it controls the excretion of potassium. So RAS is controlling the potassium excretion, and of course angiotensin 2 also has a role in the renal blood flow, in the afferent efferent arteriolar constriction, so all that. Then sympathetic stimulation. So sympathetic stimulation again will cause the activation of the RAS, because the beta 1 cells present in the juxtaglomerulus, they will activate the RAS, and similarly it will control the urine formation again. Then renal prostaglandins. Prostaglandins, we know that they have a local action. So renal autoregulation occurs at a local level by the effect of these prostaglandins. And in fact, there is prostaglandin E2, PGE2, it inhibits the action of anti-diuretic hormone, ADH. PGE2 inhibits the action of ADH. So what happens is when a patient is taking NSAIDs for any reason, the production of PGE2 stops because of the NSAID COX anti-cyclooxygenase action. The production of PGE2 suffers. So there will be no inhibition of the ADH hormone, and ADH will be able to retain much more water. So that is why it is said often that NSAIDs, they can cause water retention. Okay. So again, these prostaglandins, they have a very major role in the renal autoregulation and urine formation and the fluid and electrolyte balance in general. Then there is again another very important system known as the natriuretic peptide system. The most famous natriuretic peptide is atrial natriuretic peptide, ANP. There is BNP also, brain natriuretic peptide. There is CNP also, CNP. So ANP, BNP, CNP, they are all a part of the natriuretic system. And the function of the system is that whenever there is hypervolemia or excess of electrolytes in the body, it is sensed by the osmoreceptors, and these substances are secreted and they cause natriuresis. Natrium is the Latin name for sodium. So it causes sodium loss. Natriuretic peptides, they cause sodium loss and they cause water loss. Natriuresis. Okay. So you see there are two systems in the body which are trying to conserve the sodium, which is the RAS system and the sympathetic system, and one system in the body which is causing excretion of the sodium, loss of sodium. So a balance must exist between these three systems, otherwise there will be some diseases. Then arrangement of nephron tubules is also, it can also control the urine formation, because the cells of the PCT, they are in close contact with the cells of the ascending limb of lobe of Henle. And what are these cells ultimately going to form? The cells of the PCT along with the cells of the ascending limb of lobe of Henle, they get modified, no? They get modified and they form a special arrangement in the nephron, which is responsible for the release of renin. So what is this called? JGA. Excellent. So juxtaglomerular apparatus is formed by these arrangement of these nephron tubular cells, which again is related to the trans. So all that is about the regulation of renal function. So the maximal natriuretic response to a diuretic can give a clue to its site of action. Usually, the diuretics which are acting at the final site, which is site 4, collecting duct wala. So by that time, already much of the reabsorption has already occurred at site 1, 2, 3. So any diuretic which is blocking the site 4 will be a weak diuretic, because already a lot of reabsorption has occurred. Okay. Whereas the ones that are acting at initial sites may be more powerful. Site 1 या site 2 पे जो काम कर रहे हैं diuretics, they will be more powerful logically. But theoretically it should be that the PCT, because when I told you that PCT has maximum reabsorption, but the thing is that PCT is also dealing with the buffer system of the body, because bicarbonate, by and large, it forms the buffer system of the body. And if you block that bicarbonate reabsorption, the pH imbalance can occur in the blood. A lot of acid-base imbalance can occur. And so because of these reasons, carbonic anhydrase inhibitors, they are not very good diuretics. They are not considered very good diuretics. We'll be covering their other drawbacks also in the next class, not this one. So it appears that the diuretics acting on PCT should be the most efficacious. However, these agents are either too weak or they cause distortion of the acid-base balance, like I told you, due to bicarbonate. Also, if the PCT gets blocked due to one diuretic, the body has this compensatory mechanism, or I should say the nephron has this compensatory mechanism where the later parts of the nephron, that is the loop of Henle, the DCT and the collecting duct, they will undergo hypertrophy. In order to compensate for the blockade at PCT, they will undergo hypertrophy and they will cause excessive solute reabsorption at these sites. So in net effect, there is not much diuresis. If you block PCT, there will not be much diuresis because of compensatory hypertrophy and because of distortion of the acid-base balance. So because of these two reasons, we don't usually use carbonic anhydrase inhibitors which act on the PCT. Okay. So the extent of diuresis can also tell you the site where the diuretic is acting. So a weak diuretic will be acting on later sites like site 3 and site 4, and a stronger one would be acting on site 2 mostly. So now that we went through all that, anatomy and physiology, the pharmacology now begins. So diuretics, these are simply defined as drugs which cause a net loss of sodium and water in the urine. Okay, as simple as that. The drugs causing net loss of sodium and water in the urine. There is a little bit of history which I will not bore you with. So just quickly I'll tell you that first of all, there were organomercurials in the 1920s, and later on carbonic anhydrase inhibitors, they were the first diuretics. And interestingly, they have a structure which is very similar to sulfonamide diuretic, the sulfonamide antibiotics. And जब आप antibiotics का chapter when it will begin, you will realize that sulfonamides themselves have carbonic anhydrase inhibition wali property. So that is because of the structural similarity between these two agents. And later on, the thiazide, these diuretics, they had a lot of side effects. So later on, thiazide diuretics came, and in the mid 1960s, the loop diuretics started coming, which is like furosemide, and they revolutionized the diuretic use. And the latest entry in the diuretic world was the potassium sparing diuretics, that is the aldosterone antagonist. That was about the evolution. This again is from KDT only, the classification of diuretics. So हम यहीं पे end करेंगे आज. But before we end, I want to just tell you the names so that in the next class, when you hear those names again, it gets a little re-emphasized in your mind. So diuretics, you can divide them according to the efficacy. So those diuretics which are highly efficacious, they are called high ceiling diuretic. तो high ceiling इसलिए कहते हैं, आपने अगर dose response curve, if you remember the dose response curve, there is something known as the ceiling effect. You know? When there is a plateauing of response, when after, even if you add more drug, more dose, there will be no more increase in the response. So that phase is called the efficacy or the ceiling effect. Okay. So high ceiling means high efficacy. Okay, this will be asked many times in the Viva. People you are asked that why are they called high ceiling diuretics? So this is the answer. Okay. So high ceiling because they act on the sodium potassium 2 chloride transporters, which is present in the ascending limb of loop of Henle. इसीलिए इनको loop diuretics भी कहते हैं. That is why these diuretics, they are also called loop diuretics. So the examples are furosemide. So they all end in ide. Bumetanide, furosemide. Furosemide is most important. So, you know, this just a difference between the American and the English. The English like to call it furosemide and the Americans call it furosemide. So the compound is the same, little bit of difference in the name. Then there are medium efficacy diuretics which inhibit the sodium chloride symporter. This symporter is present at site 3, which is the cortical diluting segment of loop. So इसमें there are thiazides and thiazide-like diuretics. The thiazides are hydrochlorothiazide, hydroflumethiazide, benzthiazide, and thiazide-like diuretics are chlorthalidone, metolazone, methamide, indamide, and clopamide. So what you can remember is you can remember hydrochlorothiazide and you can remember chlorthalidone, at least for now. कहीं से तो शुरू करेंगे. Or the last class is the weak diuretics. So weak diuretics are those which are acting on the PCT, like carbonic anhydrase inhibitors and osmotic diuretics. You've already studied carbonic anhydrase inhibitors in your ANS class. So acetazolamide, carbonic anhydrase inhibitor, and osmotic diuretics, you have mannitol, isosorbide, and Distal. Then you have potassium sparing diuretics. So they can be either aldosterone antagonists or renal epithelial sodium channel inhibitors. So aldosterone antagonists are, they have like steroidal names. जैसे progesterone होता है ना, वैसे there is spironolactone, or testosterone, progesterone, basically spironolactone, plerinone. So these are aldosterone antagonists. And then, as somebody mentioned, renal ENaC. ENaC is epithelial sodium channel inhibitors. So renal ENaC inhibitors, amiloride and trimethyl. Okay, so this is where we will start from next time. This diagram is showing you where different classes are acting. So at PCT, carbonic anhydrase inhibitors and osmotic diuretics are acting. In the ascending limb, loop diuretics are acting. In the cortical diuretic segment, ये गलत है, distal convoluted tubule नहीं है. In the cortical diuretic segment of loop of Henle, thiazides are acting, and the distal tubule are collecting duct. The aldosterone antagonists and the ENaC inhibitors.